5 seconds to pause the video and read the question, and then we'll go through the answer. All right, so like I said, you have to know these diagrams. I know they're kind of a pain to memorize where all these arteries are at, but they come up very frequently. So let's just go through this, see if we can make some sense of this. Okay, so 33-year-old female, she has gross hematuria. This doesn't strike me initially as a aneurysm question, but I think you already know where this is going based on reading this. So she has flank pain over the 6 months. So it's kind of chronic, no recent trauma. Okay, that's important. But she nearly collided with another vehicle while driving a few weeks ago because the other car came out of nowhere. That's pretty important. But I think the fact that we get the peripheral visual field findings here, it kind of gives it away. So family history is significant for cerebral hemorrhage. Blood pressure is elevated. And we have the peripheral field findings also. Her renal ultrasound reveals significant diffuse cystic disease in the bilateral kidneys. Now, what is this finding here? This is bitemporal hemianopsia, okay? Something that we should be, this is the most high yield visual field finding that we talked about when we did the vision lecture. What would predispose this patient to having bitemporal hemianopia? That would be an anterior communicating artery aneurysm. Remember, the posterior communicating artery aneurysm would be classic for oculomotor lesion, and that's not even listed on here. So we don't even have the posterior communicating artery on here labeled, right? So the only things I have labeled are A, which A would be the internal carotid artery, right? So if you're not sure what these are, pause the video and go through and tell yourself what you think each of these are. Okay, so A is the internal carotid artery. Let's just say that I had a calcification of the internal carotid artery. What would my visual field finding be? It should usually be something like this, right? So it would usually affect the nasal visual field. Okay, so the nasal visual field would classically be affected if it was an internal carotid artery calcification. So it might be a unilateral nasal hemianopia. Okay, so that might be an example of an internal artery calcification going back to our vision lecture. B is going to be the basilar artery, kind of running up in this region that's connected by the two vertebral arteries. So again, if you had bilateral infarction here to the ventral pons, perhaps you can make a case for a locked-in syndrome. Really, that's not even, consistent at all with this patient's presentation, though. That would be more of the quadriplegia, horizontal gaze palsy, and arthria, right? What we talked about in the last video. Okay, so what is C? So C is the middle cerebral artery. Again, nothing very consistent here with middle cerebral artery findings. We would be looking for things like contralateral hemiparesis, maybe some cortical signs. And from a vision perspective, we definitely wouldn't expect bitemporal hemianopia. We could, if you hit the LGN from an MCA infarction, you might have a contralateral homonymous hemianopia, right? You might have something like this. Okay, or you might have, if you just affected the temporal lobe, if you just had Meyer's loop, you might have your pie in the sky, right? So the pie in the sky would be something like this, a contralateral homonymous superior quadrantopia. Okay, but that's not what we're seeing here. We're seeing a bitemporal hemianopia, which is not consistent with an MCA lesion. And D is going to be affecting the anterior cerebral artery. Again, not really in close association with some of these findings here on the imaging or the findings that are mentioned in the question. Usually this would be lower extremity contralateral weakness or sensory loss. So E is the anterior communicating artery, right? That's the anterior communicating artery, and aneurysms in this region are very classic for causing a bitemporal hemianopia because they compress on the optic chiasm. And these aneurysms are also very classic in patients that have autosomal dominant polycystic kidney disease, which is probably what this young female has. That would explain her gross hematuria. It would explain some of her worsening flank pain potentially. And it would also explain the berry aneurysms that are formed at the anterior communicating artery, predisposing her to the fate of some of what her father and her grandmother underwent with this cerebral hemorrhage. If we're really being technical, it would be a subarachnoid hemorrhage that we would most likely be expecting, not a intracerebral. But in any case, I think we have enough evidence here to safely say that this is most likely a berry aneurysm, and it is at the location of the anterior communicating artery as evidenced by the visual field deficit.